good evening, all of you, and good morning to other geographies. We have delegates from other parts of the world as well. I'm Dr. Neera Gupta, and I support medical affairs from Biocon Biologics. It gives me immense pleasure to welcome all of you for this scientific event, an educational event on breast cancer, optimizing treatment outcomes. We know that outcomes are still not there in terms of when we talk about metastatic breast cancer, and advancements are happening at much rapid pace. So such events will help us coming together and finding the best for our patients. So for setting the context, I'll invite Dr. Ashok Vaid sir. He is Chairman and Director, Medical Oncology, Hemato-Oncology, Medanta, the Medicity, Gurgaon. Over to you, sir.
Thank you, Dr. Neera, and thanks first and foremost for organizing this very interesting meeting. And as already pointed out, there are challenges in treatment of metastatic breast cancer. Only a handful of patients, small percentage of patients, live to see a time beyond 5 years, and most of them would suffer multiple recurrences, and it becomes a challenge in the subsequent lines of therapies to choose the treatments. And can somebody share my slides, or should I?
Yes, sir. I'll do that, sir. I'll do that.
Thank you. Thank you. So, breast cancer continues to be a major global problem. And as you see on the slide in front of you, these are the global data for most of the malignancies. And breast cancer is 22,61,000 cases, which is a huge number. And thankfully, the mortality from breast cancer is not as high, and one can see the mortality is at 6,84,000. But then these figures are deceptive, because the mortality and also the early detection in the Western world leads to a lower mortality, better outcomes, and in this part of the world and other developing countries, since the detection is late, therefore, the outcome of the disease is not as good. And therefore, we have an additional challenge of a higher disease burden, be it the early disease, operable disease, and also be it the metastatic disease. Next slide, please. Look at the Indian figures, and remember, out of the 22,61,000 cases, India contributes to close to about 1,80,000 cases, 1,78,000 cases to be precise. And this is a real change in the last about 20 years, that with the rapid urbanization, changes in the lifestyles, our diet, and so many others, that the incidence of breast cancer amongst women has gone up, and it's clearly the #1 cancer. Next. So in the metastatic setting, there are challenges, as already pointed out. The challenge is to maintain and improve the efficacy and safety of treatment. Since being a metastatic disease, the quality of life would be equally important, and the prolongation of life becomes the primary goal of treatment, and also the improvement in the quality of life. The convenience and adherence to treatment, since there are multiple visits to the hospitals, some tests, surveillance visits, those are required, and therefore the therapies which are going to be more convenient and more patient-friendly are going to be better accepted. And in the Indian context, there is no debate about the cost efficacy, unless something dramatic happens and the insurance cover or the third-party payments, they become better and better, which is not going to happen overnight. Next. 3 segments, the ER positive, clearly go for anti-estrogen therapies. HER2 positive, they go for the HER2 directed therapies, and we have a plethora of them in both these segments now. The anti-HER therapy could be combined with one of the CDK4/6 inhibitors, and the HER2 new in combination with chemotherapy as the frontline treatment, and in the event of subsequent recurrences, the later lines of HER-directed therapies, which are now fast expanding in terms of the monoclonal antibodies and the oral therapies as well. The triple negatives, clearly there are no clear targets. Chemotherapy is the frontline treatment, and of course, immunotherapies are exciting. They are being developed and being tested, but still not as a standard of care. Next. So also are questions which are to be addressed, and these are important from the Indian perspective: biologics and biosimilars, access to treatment, more patients getting treatment, and therefore probably one could see better outcomes even in the metastatic disease if patients have better access to therapies. And biologics versus or in combination with chemotherapy, older agents versus the newer agents. What is the gainful achievement with the newer agents? They're expensive. Could it be the older agents which could be tweaked and could be used in a more meaningful manner? And monotherapy versus sequential therapies, because in the metastatic setting, as I said, the toxicity and the quality of life also remains an issue. Cost versus cost efficiency, I've already dealt with. I think with that prelude and a brief introduction to the topic of metastatic disease, we are really excited to hear the next two speakers, very eminent speakers. And over to you, Dr. Neera, with once again, thanks and my gratitude.
Thank you so much, sir, for setting the context so aptly. As you have shown the three main types, and today's event, we are covering the two main topics of anti-HER2 as well as triple negative. So triple negative are tough to treat disease area. And for this, I'll invite none other than Dr. Ajay Bapna, sir, Director and Head Medical Oncology, Bhagwan Mahavir Hospital and Cancer Center from Jaipur. He'll be talking about current concepts and management of triple negative breast cancer. Over to you, sir. Sir, please unmute yourself.
Thank you, Dr. Neera, for the kind invitation. And thanks to Dr. Ashok Ved also for making me the part of this important meeting. As you correctly said that the triple negative breast cancer really, it's not moving.
So just click on the screen, then it will move.
Okay. Where?
Normal on the presentation, just click on the presentation.
So as Dr. Neera mentioned that this subtype of the breast cancer really intrigues all the medical oncologists because every other year, the treatment of the triple negative breast cancer changes. So the actual question was, what poses us the challenge is that do we need to select the better patients or the better drugs? So at the end of my discussion, I think we will have some answer. So the triple negative breast cancer is an aggressive histologic subtype, and it accounts for 10% to 20% of all invasive breast cancer. And it is associated with younger age, higher disease stage, and increased risk of relapse. So these are the three things which really poses challenge to all the medical oncologists globally. And above all, the metastatic triple negative portends a very poor prognosis, and we really need to do something for the metastatic triple negative breast cancer. And the median overall survival of approximately 17.5 months with the first line chemotherapy. So this is how you can understand that it carries a really poor prognosis. So why we didn't have the breakthrough so far was because we didn't understand the biology of the triple negative breast cancer. But with the continuous research, now we have multiple novel targets in the triple negative breast cancer. And every year there is the drug introduced which takes care of these novel targets. And a time will come when we will be treating this triple negative breast cancer, which hitherto was a difficult cancer to treat, will be treated just like lymphoma. So the novel target for in the triple negative breast cancer and the drugs which will be used are mainly the AKT inhibitor, where sometime we'll be using the abatacept and capivasertib, AR inhibitor like bicalutamide and enzalutamide, trilacyclib, PARP inhibitor like olaparib, talazoparib, veliparib. Antibody drug conjugates are already in the scene like sacituzumab govitecan and the ladrizumab vedotin, and the immunotherapy has already been introduced and have been used in the triple negative breast cancer. Sometime in due course, either they will be used alone or in the combination, because we really need to address all these novel targets. So this was a paper which was published in Journal of Clinical Oncology, which really looked at the multidimensional molecular profiling of the metastatic triple negative breast cancer and immune checkpoint inhibitor benefit. So this article, the informed us that all triple negative breast cancers are not bad. There are some triple negative breast cancer which have good outcome, and there are triple negative breast cancer which have worse outcome. Which are the triple negative breast cancer which have good outcome? These are high tumor mutational burden, the tumor which have presence of CD8 cells, CD4 memory T cells, follicular helper T cells, M1 macrophages, and the tumors which have inflammatory gene expression pathway. So these all will have good outcome. In comparison to the patient who have worse outcome includes the pre-treatment deficiencies in the homologous recombination DNA damage repair pathway and the absence of minimal clonal evolution post-treatment. So eventually the molecular subtype of triple negative breast cancer were defined by the Lehman and colleagues, and they analyzed 587 triple negative breast cancer cases in 21 publicly available data set to identify the molecular subtypes. So these were the subtypes which were identified by the researchers that breast cancer is a heterogeneous disease, it's not a one disease. So molecular subtypes are based on the unique gene expression profile, and it divides triple negative breast cancer into at least 6 subtypes, like basal-like 1, BL1, basal-like 2, which is also called BL2, immunomodulatory, mesenchymal, and mesenchymal stem-like and luminal androgen receptors. So we need to address all these subtypes very differently to have a some breakthrough in treating the triple negative breast cancer. Then only we will get the success. And it is also very important to understand the genomic features. What are the genomic features of the molecular subtypes, which just now I had mentioned? The genomic features are that there is a high genomic instability, frequent somatic mutation in TP53, which is present in 82% of the cases, and PIK3CA mutation, which is present in 10% of these cases. 20% of these cases will have germline or somatic BRCA1 or BRCA2 mutations. Copy number analysis also found significant amplifications, which include the PIK3CA, KRAS, BRAF, EGFR, deletion in the PTEN, and deletion in the INPP4B. So, now you can understand that this disease is not as simple as it sounds. It's a complicated disease. And at the same time, the heterogeneity of the tumor immune microenvironment also plays a very important role in the prognosis of triple negative breast cancer, which mainly includes the extracellular matrix and stromal cell types, which again include the immune cells, tumor-associated macrophages, cancer-associated fibroblasts, and cancer-associated adipocytes and endothelial cells. So, beside the cellular component, the microenvironment also plays a very important role in the prognosis of triple negative breast cancer. Alteration in the microenvironment significantly influences the tumorigenesis, disease progression, and response to treatment. The presence of TILs in the triple negative breast cancer are associated with greater response to both neoadjuvant and the adjuvant chemotherapy. So as I had already elaborated, that there are 6 subtypes of molecular subtypes of the triple negative breast cancer, and it has a bearing on the relapse-free survival. Like BL1 tumor, they are higher grade, but present with the lower stage with increased relapse-free survival and the overall survival. BL1 tumor were also most likely to achieve PCR with standard neoadjuvant chemotherapy, but it is not translating into overall survival. Luminal androgen receptor LAR tumors had higher regional spread and regional lymph node involvement, and this tumor also preferentially metastasized to the bone, consistent with the disease course of ER positive tumors. The mesenchymal tumor had higher propensity to metastasize to the lung, and the BLISS, which is basal-like immune suppressed type, had the worst disease-free survival out of all triple-negative molecular subtypes. And GLIA, which is basal-like immune-activated subtype, had the best disease-free survival. So this much at least we have come to know. So the future actionable targeted, just now we know only about the BL1 tumor. So now you can imagine that for the rest of the molecular subtype, we still need a lot of research. For BL1 tumor, a PARP inhibitor can be used because of the high copy number gains in the PARP1 gene, so-called the BRCAness. MAC1 and MAC2 inhibitors can be used because high copy number gains in KRAS, NRAS, and BRAF is present. PIK3CA inhibitor or AKT pathway inhibitor can be used because there is a high frequency of PIK3CA copy number gain, and PIK3 AKT pathway inhibitor because of the overexpression of the PIK3CA mutation, AKT2 and AKT3 genes. So only a subtype of triple negative breast cancer can be benefited using these molecules. And regarding the mesenchymal subtype, the cell line representative of this type were responsive in the cell line to tyrosine kinase inhibitor, dasatinib, and PIK3 and mTOR inhibitor. Let's see how these molecules behave when we use it in the clinical setting. But because just now they have shown response in the cell lines. So definitely whatever we have discussed so far, it is very clear that the triple negative breast cancer, it is a breast tumor with an identity crisis. So these are some of the landmark trials which were used in the neoadjuvant setting. So there are multiple trials, and the addition of the immune checkpoint inhibitor to neoadjuvant chemotherapy was shown to improve the pathological complete response regardless of the PD-L1 status only in the 2 trials out of these 9 trials, which has also demonstrated the event-free and disease-free survival benefit with immune checkpoint inhibitors, regardless of whether pathological complete response is achieved or not. Currently, there is insufficient data to recommend using the immune check inhibitors in the neoadjuvant setting other than the pembrolizumab. So the proposed treatment algorithm for early stage breast cancer so far in 2022 is, if you have an early stage triple negative breast cancer, if the surgery is performed and there is a complete pathological response, then you can use the adjuvant pembrolizumab. And there is a future enrollment is also planned in the trial which was initiated in this setting. And if these patients, after receiving the neoadjuvant chemotherapy and after undergoing the surgery, if there is no pathological complete response, then you will look whether the patient has the germline BRCA1 or BRCA2 mutation or not. If these patients who have not achieved pathological complete response and germline BRCA1, BRCA2 mutation is present, you have options of using the adjuvant pembro. Consider concurrent or sequential olaparib with pembrolizumab. If there was no pathological complete response was achieved, based on the CREATE-X trial, you can use the capecitabine after completion of the radiotherapy if the patient is planned to receive the radiotherapy. Otherwise, for the patient who have received the pembrolizumab in the neoadjuvant setting, will go for the adjuvant pembrolizumab. And concurrent pembrolizumab can be used with the radiation. So, this is in brief how you should deal with the early stage triple negative breast cancer. So these have been aptly put in the NCCN guideline also on version 4 2022, where the high risk triple negative breast cancer preoperative pembrolizumab, carboplatin, paclitaxel followed by preoperative pembrolizumab, cyclophosphamide, doxorubicin, or apurubicin followed by pembrolizumab, which got the FDA approval in July 2021. But if you look at the preferred regimen, none of them is category 1. So it's entirely the discretion of the medical oncologist which regimen the medical oncologist wants to use. All are considered as the preferred regimen. So now, after discussing the early stage triple negative breast cancer, now a few words about the metastatic setting. In this setting, this was the landmark trial Keynote 355, which was the patients were randomized into the pembrolizumab 200 milligram IV 3 weekly plus chemotherapy. Chemotherapy was as per the physician's choice and was compared with the placebo and the chemotherapy. So this was published in July 21, 2022 in NEJM also. So what was the result of this trial? So the first Kaplan-Meier curve clearly shows that with a combined positive scores of 10 or more, you can see there is a very early separation of the both the curves, and the patient who received the pembrolizumab plus chemotherapy with CPS score of more than 10 were largely benefited. In comparison to the patient, which you can see in the second Kaplan-Meier curve, the PD-L1 with CPS of 1 or more, there was late separation of the curve, and patients were not benefited as much as with the patient who had CPS of more than 10. And if you put the data all together in an intention to treat population, then you have the mixed result. But clearly, it was shown in the forest plot also. Now you look at that the patient who were benefited most in the metastatic triple negative breast cancer were the patient who had CPS of more than 10. So this is the only setting where you should really use the immune checkpoint inhibitor. The conclusion of this landmark paper published in NEJM informed us that among patients with the advanced triple negative breast cancer whose tumor expressed PD-L1 with CPS of 10 or more, the addition of pembrolizumab to chemotherapy resulted in significantly longer overall survival than chemotherapy alone. So this became the standard, and currently we are also using this protocol, and this has been also put appropriately in the the NCCN guideline version 4/2022, where if you have the triple negative breast cancer, PDL expression using the 22C3 antibody and CPS more than 10, it has been given the category 1 recommendation. This is in comparison to the immune check inhibitor in the neoadjuvant or the adjuvant setting, where the category was 2A. So this has become the standard of care and is the preferred first-line therapy. So other recent advances beside the immune check inhibitors in the triple negative breast cancer is the FDA approval in 2022 of sacituzumab govitecan for later lines. So there are multiple drugs available, as I showed you in the beginning, that there are multiple targets. So the immune checkpoint inhibitor are not only the panacea for triple negative breast cancer. What we need to understand that the genomic profile and other sequencing technology have led to the better understanding of the heterogeneous biology of triple negative breast cancer and has allowed for the identification of various molecular subtypes of triple negative breast cancer, which will be treated very differently. A variety of genetic alteration found in TP53, BRCA1, BRCA2 mutation, KRAS, NRAS, and PIK3CA genes, amongst many others, and the disruption in their associated cellular pathway provide opportunities for the novel targeted treatment. The molecular studies have also uncovered the heterogeneity of the tumor microenvironment with triple negative breast cancer subtype, including the vast differences in the immune infiltrate localization, composition, and expression of the targetable immune pathways. The success of immune checkpoint inhibitor in clinical trial have led to the approval of atezolizumab in combination with the nab-paclitaxel in the metastatic setting and approval of pembrolizumab in the neoadjuvant setting in 2021. The first TROP2 antibody drug conjugate sacituzumab govitecan was also approved in early 2022 for the refractory metastatic triple negative breast cancer in later lines. This new approval signify a long-awaited change in the treatment landscape of triple negative breast cancer, but nevertheless, these treatments remain restricted to a small subset of the triple negative breast tumors, and the novel treatment strategies for triple negative breast cancer, such as combination treatment with both molecular target as well as the immune checkpoint inhibitor, in combination with the vaccines to enhance the T cell priming and activation are underway, So in due course of time in future, probably we will answer to all these questions. So given the opportunity for the metastatic triple negative breast cancer, for my first line treatment will depend on the PD-L1 expression. It will not depend on the BRCA status. Even in the first line setting, I would look into whether the patient is eligible for a clinical trial or not. And then I will look whether the patient is PD-L1 positive or not. I would choose chemotherapy plus immune checkpoint inhibitor, regardless of whether the patient is BRCA wild type or carries a BRCA mutation. And the PD-L1 negative patients, I would select chemotherapy. And you all know that the anthracycline and taxane make the backbone of the chemotherapy. And if there is a BRCA mutation is identified, a PARP inhibitor may be used. So this is my approach for the patient for the first line treatment. And for the later line treatment, which will be influenced largely by the BRCA status of the tumor, relapse timing, and the toxicities of the previous chemotherapies. And for the subsequent treatment, if the patient has that mutated BRCA 1 or 2 and has not previously received a PARP inhibitor, then I would consider a PARP inhibitor for second line treatment. Sacituzumab govitecan I would reserve as a third line. And for what will we do for the patients who have wild type BRCA? In these patients, I would decide between the second line treatment with chemotherapy versus sacituzumab govitecan, where it can be used a little bit earlier. If the patient has progressed within the 12 months of neoadjuvant chemotherapy, I would likely select sacituzumab govitecan and reserve chemotherapy for third line treatment. And if the patient did not have an early relapse, then I would sequence chemotherapy before sacituzumab govitecan. Similarly, the trastuzumab deruxtecan offers another unique targeted therapy option, but additional trials are needed to understand the appropriate use of trastuzumab deruxtecan in metastatic triple negative breast cancer. So to conclude my talk, I would like to say that the immune checkpoint inhibitor represent a much needed addition to the limited armamentarium against triple negative breast cancer. Positive results of the addition of the anti-PD-L1 antibodies to chemotherapy across several phases, phase 3 randomized controlled trial in both first-line metastatic and neoadjuvant setting are encouraging. Given the historically dismal outcome of this disease, these findings necessitate the adoption of immune checkpoint inhibitor as a standard therapy for patients with stage 2 and stage 3 triple negative breast cancer for those with PD-L1 positive advanced triple negative breast cancer and advanced triple negative breast cancer. Novel strategies for PD-L1 negative advanced triple negative breast cancer are needed, and biomarkers to select the patient with neoadjuvant immune checkpoint inhibitor therapy, which require refinement to facilitate chemotherapy de-escalation. Future strategies, including the synergistic combination with other immunomodulatory molecule, including the targeted therapy for a select population, could be promising. The combination of the PARP inhibitor with immune checkpoint inhibitor is of major interest given the incidence of BRCA1, BRCA2, and PALB2 and other homologous recombinant repair gene alteration in triple negative breast cancer. The additional evaluation in randomized phase 2 and phase 3 trial is warranted, and there are several ongoing trials, including Impassion 132 and BELA, are evaluating immunotherapy for patients with early relapse within 12 months after the curative intent therapy. Similarly, the Alexandra and Impassion 030, ZPAR, DOOS, NSABP B59, which are looking for the use of atezolizumab in the neoadjuvant setting. But the results are yet not out, and let's see what in the future this trial tells us. So the question which was asked was raised in the beginning, that the immunotherapy in triple negative breast cancer, do we need to select better patients or the better drugs? The answer is very clear from the discussion we had just now, that basically you need better drugs or maybe a combination for sure to treat this the disease, triple negative breast cancer. which is really, a very difficult disease so far in treating these patients. Thank you very much for your kind attention.
Thank you so much, Dr. Bapna, sir. Great talk for such a complex topic. I understand tumor biology is like so difficult to understand and transfer the benefit to these patients. Thank you so much, Dr. Vaid, sir, and Dr. Shyam Agarwal, sir. If you have any burning question for Dr. Bapna, let's have that before we move on to the second talk.
None from my side. Dr. Shyam.
Yeah, I think we can go ahead.
Yeah.
Okay, thank you so
Great.
much.
Thank you once again.
Thank you, Ajay, for that wonderful lecture.
Thank you. Thank you.
Thank you, Dr. Vaid, sir. We understand that Dr. Bapna, sir, has to leave for some other critical engagement on patients' front. So thank you, sir, once again for being with us.
Thank you very much.
I would like to invite Dr. Shyam Agarwal, sir. He'll be talking about HER2 positive metastatic breast cancer evolving trends. Dr. Shyam Agarwal, sir, is Senior Consultant Medical Oncologist and Chairman of Hemato-Oncology Bone Marrow Transplant, Sir Ganga Ram Hospital, New Delhi. Over to you, sir, for your deliberation. Thank you.
Thank you very much, Dr. Neera, and thanks, Dr. Ashok, for this opportunity to cover the subject of HER2 positive metastatic breast cancer. So do we have the slides?
Sir, you need to share the slides.
I have to share the slides?
Do you want me to share? Just allow me a minute.
Yeah,
I'll do that. I'll do that, sir.
So just to put things into perspective. So unlike triple negative breast cancer, HER2 is really become a treatable disease, as you will see when we go through the slides. And I'm sure a lot of you are aware of the progress which you have made in the understanding and the drug development for HER2 positive metastatic breast cancer. So it was an orphan disease maybe 15, 20 years ago when we did not have the targeted drugs available. But now, as you will see, there are a plethora of drugs, and Indian contribution has been huge in terms of developing biosimilars. And so I'll begin the presentation on these lines. Next slide. Okay, so these are the targets available for HER2, HER3, and how these drugs are developing. So we all know trastuzumab was the first one to target HER2, but then in the extracellular domain, we have the emergence of 4 new agents, as you can see here. Pertuzumab, which is readily available, not only targets HER2, but also HER3. And margetuximab is another new drug which is not available to us at this point in time, so I won't focus. So it has got the FC fragment related activity with trastuzumab. But what we have available is the the linker drugs with trastuzumab, that is TDM1, and we'll show you the data. And particularly this the deruxtecan trastuzumab is an important drug, which is again a linker drug, which we will see. And you can see there are 3 drugs which act on the as TKIs and lapatinib, and I'm told neratinib shortly will become available, and of course the tucatinib, which will see the data. So 9 drugs here. So which is we didn't have even a single drug maybe 20 years ago. So this has really changed the landscape of treatment for metastatic HER2 positive breast cancer. Next slide. So this has become the a kind of treatment approach to MBC HER2 positive. where earlier we were using only trastuzumab with a taxane, but now if somebody can afford, the best treatment would combine these three agents, a taxane, a trastuzumab, and pertuzumab. And then depending upon whether the patient has brain metastasis or disease is stable, one can switch to a drug like deruxtecan, which is not readily available at this point in time. And here currently we are using TDM1, but I think in due course of time, when the deruxtecan drug becomes available, then I think we will follow this particular protocol. Once that fails, then we can go on to tucatinib, capecitabine, and trastuzumab. But then again, tucatinib is expensive and is still not available in India. So currently, this algorithm is not being followed because of the non-availability of these two important agents. If somebody has uncontrolled brain metastasis, which is quite common, in patients with HER2/neu disease, tucatinib, an oral HER2/neu inhibitor, is, available, and it does cross the blood-brain barrier. And there is efficacy of the deruxtecan as well for brain metastasis. Neratinib and capecitabine combination comes down the line, and subsequent to that, you have drugs like LabCap, which is so readily available with us. So currently, in India, we are crippled because of the non-availability of these two important molecules, and therefore our algorithm revolves around pertuzumab, trastuzumab, taxane, followed by TDM1, and we still don't have neratinib, and therefore you're talking about lapatinib. So, but I think the Western world has really moved quite rapidly in the last couple of years. So we'll follow suit in the next, I think next year, hopefully, with the availability of Enhertu, which is the deruxtecan. Next slide. So this is the important slide here, which shows you the benefit of three-drug combination, docetaxel, trastuzumab, and pertuzumab. And so interesting to see here, so fascinating to see here that 8 years, 37% patients are alive. That is the overall survival. So who could have thought, maybe 20 years back, when everybody was, not surviving beyond 2-3 years, now more than 1/3 patients are alive at 8 years. And if you see the 8-year landmark for progression-free, 1/6, 16% of patients will not progress on this combination of pertuzumab, trastuzumab, and docetaxel. So this is a remarkable achievement, from HER2/neu positive metastatic breast cancer in the Cleopatra study. Next slide. So we are still, at the TDM1, which was compared with capecitabine and the lapatinib combination in patients who had failed taxane and trastuzumab. And you can see the curves a little better for TDM1, and the hazard ratio is 0.75. I mean, that's what we have at this point in time. So it is highly, unlike the use of drugs like TDX and tucatinib. Next, which we'll see in the subsequent slides. So this is the, see the tucatinib data here, and you see the hazard ratios in the range of 0.48 for overall survival, 0.66, which is so much better than as compared to TDM1. And that is why tucatinib, capecitabine, and trastuzumab combinations are so much, that's why they're moved up then as compared to TDM1. Next slide. So this is the neratinib and capecitabine study compared with LabCap combination in patients who've been treated with more than 2 prior lines of treatment. Next slide will show you the curves. Okay, so again, so there isn't, there's a little difference. You see the hazard ratio for overall survival 0.88, and for PFS, the hazard ratio is significant, and the p-value is significant here. But I think the advantage of neratinib lies in its ability to prevent the CNS disease. Next slide. Yeah, so you can see the time to intervention for CNS metastasis is sort of more for patients who are on neratinib and capecitabine as compared to compared to lapatinib and capecitabine. So, I mean, it is a good drug, but then, as you saw in the algorithm, it is used much lower down in the treatment algorithm. Next slide. So I think the treatment paradigm for metastatic HER2 in breast cancer in 2019 we are still there because we don't have those newer agents. So we use the 3-drug combination followed by TDM1, and then we have LAPCAP. And if somebody is endocrine positive, HR positive, then one can also use an endocrine drug like letrozole or even fulvestrant in combination with the HER2 new targeting. And the outcome is fairly bad beyond third line because response rates are poor. Next slide. So this is the game changer where you have trastuzumab deruxtecan. So the high drug to antibody ratio, because you can see there are 8 topoisomerase inhibitor payload, which is exatecan derivative. So this is really, and this is combined with trastuzumab. So this basically delivers the payload, and there is a bystander killing effect, and this very highly potent topoisomerase 1 inhibitor. So this has really changed the whole game for patients with HER2 new positivity. Next slide. And so this is the DESTINY-1 study for patients who have been exposed to earlier agents with the HER2 new targeted drugs. Next slide. So this is so very impressive here that virtually majority of the patients in this cartoon show response rates of 60%, and there were 12 CRs. And I mean, this is really impressive, for patients who have failed trastuzumab and even pertuzumab. Next slide. Responding very rapidly within 1.6 months. And see this curve, the overall survival and the PFS curves in this study are really impressive. At 1 year, 85% OS, and at 18 months, 74% overall survival. So this is really encouraging data. Next slide. So not only trastuzumab deruxtecan works in HER2 new positive, so-called, who are HER2 new 3+ or FISH positive, but you see the response rates for HER2 low metastatic breast cancer. And as you can see, 39% for HER2 new 2+ FISH negative, HER2 new 1+, 36%. Again, for ER positive subgroup, positivity of response rate of 40%. So this is again becoming, again an intervention for patients who are HER2 new low, and this is sort of beneficial there. Next slide. So I think, so new third line agents, you can see I showed you data for deruxtecan and tucatinib, and they're both active in brain, and therefore they have moved up because of their response rate, because of their overall survival and the progression-free survival. A word about the toxicity for deruxtecan is interstitial lung disease, and therefore you have to be careful and maybe initiate the steroids early after you identify this particular side effect. Neratinib capecitabine does come lower down, but it delays the time to CNS treatment. Diarrhea is the side effect. And this is a drug which is, as I said, with low affinity FCR, and maybe not that important then as compared to deruxtecan and tucatinib. Next slide. So I think the future revolves around these two drugs. But I think currently we have to talk about the biosimilar trastuzumab, which we have now for more than a decade with us. Next slide. Because the availability of the biosimilars, is so very important, because one can give it to a large proportion of patients who can't afford the original molecules. And if you have the efficacy with the biosimilar, identical to the original molecule, then that thing would sort of change the whole thinking in a third world country or a developing nation. And that is what this heritage study has done. Next slide. So this was, as you can see here, countries which participated were Eastern Europe and Asia Pacific, 65 and 31%, respectively. Next slide. So you can see this is a comparison of the pharmacokinetics for the MIL 14010 as compared to Herceptin US, as compared to Herceptin EU. And this is the US and the EU Herceptin comparison. And as you can see, this, the curve, which is absolutely overlapping, indicating that the pharmacokinetics are similar for all these three agents, and including the Indian biosimilar. Next slide. So this was the trial in which double-blind international study, the heritage study design, where chemo was combined with either biosimilar or with the the reference product. And next slide. So you can see 230 patients nearly in each arm with from Biocon and from the branded trastuzumab, and response rates almost identical. And you look at the the overall response rates and the ratio of so there isn't any difference between the two molecules, whether it is the Biocon product or the original from the originator. Next slide. So again, you see the same thing in the progression-free survival and the overall survival. The curves are almost overlapping. They're touching each other, and the hazard ratio and p-values are not significant, indicating whether you use the original one or you use the biosimilar, you will get the similar outcome in terms of PFS and the overall survival. Next slide. So in terms of toxicity, I mean, you don't see again any difference. If you look at various side effects, GI or nervous system, I mean, they're identical. So there isn't much. Next slide to choose between the two. This is the most important toxicity is the reduction in the left ventricular ejection fraction. And you can see a baseline at cycle 5, 9, 13, and 17. No difference in the median LVEF between the two arms. So it's similar. Next slide. So it's a true biosimilar. And immunogenicity profile is again similar incidence of anti-drug antibodies. Next slide. So this is the overall survival, 35 months for, or 30 months, not much to choose between these two. And so the median, the PFS is 11.1 months for both the groups. And if you look at the reduction in the LVEF, similar for both the groups. This is a summary slide indicating that the Mylan or Biocon drug biosimilar is giving you almost identical results to the originator molecule. Next slide. So, okay, this is the important issue of the financial toxicity in cancer care in India. So this was a publication from Senthil and from Aju Matthew, that more than nearly 50% of the patients who are suffering with cancer, they have to have out-of-pocket expenditure, which is greater than 30, 40, 50%, or even up to 84%. So the ability of the patients to purchase these expensive molecules is sort of not there because of their poor income and focus on household expenditure and the food expenditure and so on. And I mean it's really limited to less than 20-25% of the Indian population, and therefore there is a need to have cheaper alternatives for patients who are not insured or who do not have coverage from CGHS, EHS, etc. So I think the biosimilar molecule provides that opportunity because these drugs are much cheaper than as compared to the original molecule. Next slide. So the cost efficiency and expanded access modeling of conversion to biosimilar trastuzumab with or without pertuzumab in metastatic breast cancer has been reported. And this is the publication which demonstrates that if you have an equivalent molecule, these cost savings could provide more patients with trastuzumab DKST treatment on a budget neutral basis. So I think this is common sense. I mean, people can't afford. So therefore, if the drug can't reach a middle class or even less than middle class, so it is of no use if it is lying on the shelf. So I think Mylan and Biocon have done a great job in providing the biosimilar for almost a decade now or even more. Next slide. So you can see the response rates and the side effect profile, which is comparable from the originator molecule and different biosimilars, and even the side effect profile is virtually, you look at, actually the side effects are much lower than as compared to Herceptin and other biosimilars. So I think the pharma industry has really come a long way because they've really delivered potent, effective, safe biosimilars as far as trastuzumab is concerned. Next slide. So, I mean, this is the 2022, algorithm which we just discussed, that we should be using 3 drugs if possible in the first line for HER2/neu positive MBC. And the second line, as we said, deruxtecan is the drug because it is so very effective because of such impressive data. If that's not available, then it is T-DM1, and then followed by drugs like tucatinib or neratinib and margetuximab. And of course, LabCap also features in somewhere. So I think the number of patients we will lose as we go on to the 3rd line, 4th line. But who would have thought, maybe 20 years ago that we'll have 4 or 5 lines of treatment for HER2/neu positive, and that to drugs which can cross the blood-brain barrier and control the malignancy there. And the last point is that even NCCN also, gives approval for FDA-approved biosimilar for trastuzumab. So I think the Indian pharma is going all over the world because they are supplying these biosimilars not only to developing nations, but also to the developed world. Next slide. So I think to conclude here, we've already shown you the efficacy of various anti-HER2/neu therapies in HER2/neu positive, but it is also showing efficacy in HER2-low. And and that's going to change the landscape for treatment for particularly ER positive. As you saw, the response rates were really impressive for HER2-low with the deruxtecan. So several lines of treatment and the availability of Biocon's trastuzumab is changed in the ability to penetrate even the middle class or lower middle class population, and therefore giving promising results in HER2/neu positive breast cancer with metastatic disease. So with this, I think I stop here and thank you for your attention and this opportunity.
Thank you so much, Dr. Agrawal, sir. It was great presentation and very nicely alluded. Thank you so much, Dr. Vaid, sir. I'll seek your help over here now to facilitate the discussion.
So thank you, Dr. Shyam, and thank you, Dr. Bhavna, who had to leave, but it just can't get better than that. Dr. Shyam, it was an excellent exposition, and you covered the topic so very well, and I'm sure all the students on the program would have benefited so much from this. There are a couple of questions in the question box, Dr. Sham. They are mostly related to the HER2 news segment. And the first one is that TDXT optimal dose, position and duration of infusion, management of complications. I think this is more related to the logistics part of it, the administration part of it.
Correct. So since I don't know, have you used the drug at any stage, Dr. Ved?
I haven't.
Right. So we don't have access to the drug, and therefore I won't be able to sort of tell you on that front that how it is to be, constituted and sort of given. So
that's a very clear sort of this thing. We had the opportunity to counsel 2 families, but I think one of them, because of the background lung dysfunction, had to be sort of excluded. And as you very rightly pointed out, that the ILD is a real issue with these patients, and one need to. The other patient obviously couldn't get onto it for financial reason. It's a mighty expensive drug. And I don't think the overall the administration and all that is going to be a real challenge, because it's like any other monoclonal antibody. The second question is that, does heredity play a role in evaluation of the risks? Probably I couldn't understand risks of heredity.
Yeah, right. I think if somebody has a family history of breast cancer or ovarian cancer, and the index patient is suffering from breast cancer, now with the availability and the understanding of PARP inhibitors, it is imperative on our part for metastatic disease to do the BRCA1 and BRCA testing for sure, because as was alluded to by Dr. Bapna, that PARP inhibitors are going to be on in a TNBC setting, maybe in the second or even third line. But you have to have the BRCA1/2 test done on, and I think currently it is only the germline testing which is being done in patients with breast cancer, when we are talking about breast cancer here. So I think there are guidelines to do the BRCA1/2 testing in the metastatic disease, especially for TNBC under the age of 50-60 years, or there is a family history of breast cancer in 1 or 2 relatives, particularly first degree relatives. And then the data is also on for early breast cancer, high risk, because PARP inhibitor like olaparib is approved there. So, the understanding of BRCA1/2 when to do is very, very critical today because of the availability of a potent drug like olaparib.
Thank you, Dr. Sham. And the last question is that, how to assess if pertuzumab is working for the patient?
Right. So I don't really understand this question too well, but I think as I said, we're not giving this as a single agent. The pertuzumab is combined with trastuzumab and a taxane, maybe docetaxel or paclitaxel. So it is the combination which is giving you the benefit. So which is better than the chemo plus trastuzumab alone. So it is not possible to dissect which patient is not going to benefit from pertuzumab. So therefore, all patients who have MBC, who are HER2/neu positive, need to be given 3-drug combination. So this question is not going to be, we're not going to be able to answer in any way because it is not possible to dissect.
So when this combination fails, obviously we have to move to the second line. All 3 are equally implicated in this.
Correct, because as I showed you, the overall survival with the triple drug is 37% at 8 years. So which is more than 1/3 of the patients living. So that is only possible if you keep, so you give the chemotherapy for 6 months, and then you keep doing pertuzumab and trastuzumab for 7-8 years in 37% of the cases. I mean, that is overall survival. I'm sure some of the patients will relapse. And as I showed you, 16% will not progress, which means that at 8 years, 16% of the patients are getting both the drugs for 8 years and ongoing.
1 in 6.
1 in 6, right? So that's amazing. I mean, I'm sure you have patients. I have a couple of patients who are going on trastuzumab and pertuzumab for more than 5 years.
Thank you, Dr. Sham, for that. But let me take you back to the immunotherapy, the IO story once again, because it's a dilemma in today's time. There is data to suggest that the neoadjuvant, we have also practiced it. Who clearly should be offered a neoadjuvant IO in the face of the fact that drug is still not approved in that setting in India, though there is approval by the FDA and in the metastatic setting. So the question has two parts: in the neoadjuvant and in the metastatic setting.
So I think the guidelines are fair there. For neoadjuvant setting, you don't need to do the the PD-L1 testing. So it is approved across the board in combination with a taxane and a platinum for triple negative. And pembrolizumab is the approved agent in the neoadjuvant setting. When it comes to the metastatic disease, as was shown, we need to do the CPS scoring, and patients who have CPS score more than 10 are the most likely beneficiaries for pembrolizumab in the metastatic disease.
Thank you, Dr. Sham, for that very crisp answer. And I don't see any other questions in the chat box. And any other questions from the participants here, or Dr. Neera, anything from your side? I hand over the proceedings back to you with many thanks to both the eminent speakers, all the participants this evening. More than 300 of them have registered, they are participating. It's a good number, and I hope everybody benefited out of the deliberations and the proceedings this evening. Thank you so much once again.
Thank you so much, Dr. Vaz, sir. I will invite Kalpana Pai. She is Head of Commercial Excellence at Biocon Biologics to cast the formal vote of thanks. Over to you, Kalpana.
Thank you so much, Dr. Neera. And it is always a pleasure to hear Dr. Shyam Agarwal, to have Dr. Vaid for facilitating, and Dr. Papna. I really enjoyed and learned a lot, so really thanks. And on behalf of Biocon Biologics, many thanks to come on this platform on this day. I know you all are so busy with your patients, but you agreed to come on this platform. And it's really a very interesting platform wherein you're disseminating the science to the students, which we strongly believe, because connecting and catching the doctors young and clearing their doubts is something which would help in future for them in their clinical practice. I'm sure these interactions have helped all our audience. We have more than 100 who are online with us, and your clinical pearls, sir, your tips to them have really helped. So many thanks, and we want to do many more such things for both global, because Biocon is global, especially when we have integrated now with the the Viatris. So we would want this thing to continue, so that many more doctors globally will also get benefited with your experience, hands-on experience in this field. So many thanks once again, and many thanks to our tech partner MICE, and also our sales and marketing folks who have really made this successful, and the audience who have actually gained a lot from you all. So thanks a lot, and very good night, and thanks for the rest of the day. Have a nice day.
Thank you.
Thank you.
Thank you. Bye-bye.
Thanks.
Thank you.
Thank you. Bye-bye.